a common endocrine disorder in reproductive women. Its prevalence is 8 to 13% in reproductive age. It can be up to 30% in high-risk population. However, 70% of patients are undiagnosed. Why is it so? So I have included an example in the side box. That is, you can see the cartoon. In this, you can see a woman is reaching out to a person. It can be a family member or it can be a healthcare provider because she thinks that something is amiss. But you can see that she's being dismissed or just ignored, saying that you look like a normal patient. So that's how most of the cases, they go undiagnosed or it can be diagnosed late. So this is a world map showing the worldwide prevalence of PCOS. So you can see that the prevalence varies with the population being studied, and also it depends on the diagnostic criteria which is used. So you can see the different ethnic population will have the varying features of PCOS. The severity also will differ among the ethnic population. So for example, the Caucasians, they have relatively mild phenotype. However, the BMI can be high, especially those from North America and Australia. So let us look at the Southeast Asian side. In Southeast Asian population, the metabolic features are more prominent. These include visceral obesity, otherwise called central obesity, and insulin resistance. It can be impaired glucose tolerance or type 2 diabetes, and they can also have Acanthosis Nigrikens, which is a sign of insulin resistance. So Southeast Asian population, they are more prone for metabolic problems. And also you must remember, East Asians, they have low BMI, and also the hirsutism is very mild. This you need to take into account when you are diagnosing PCOS. And in Middle East population, the severity of hirsutism will be more. And Africans, on the other hand, the BMI can be high, and also they can present with metabolic features, Africans. But there is, as you can see, the data is not complete because of underreporting. So what are the risk factors for PCOS? So the risk factors can be, it can be a heritable condition because you can know it runs in families, or it can be due to lifestyle changes, which can be like, decreased physical activity. And during this pandemic, you can include as a environmental factor. You all know this extensive lockdown has caused a lot of issues with the confounding factors like financial loss, and also almost no physical activity for a particular period of time. All these have added fuel to the fire, and it's really a ticking time bomb for the healthcare professionals. And another issue is the neuroendocrine problem, which can cause dysfunction of the HPO axis. And obesity is also another risk factor, mainly because of visceral obesity. So you must know the pathophysiology of PCOS. The pathophysiology of PCOS is not clear. However, there are three key features which are involved in pathophysiology, mainly insulin resistance and androgen excess. The last one is LH hypersecretion. These three factors are interlinked and they complement each other in a vicious cycle. So you can see in this schematic diagram that there is increase in insulin levels. So there is glucose tolerance, decreased glucose tolerance, and this increase in insulin can cause a decreased secretion of sex hormone binding globulin. So in turn, the free androgen levels can be increased, resulting in androgen excess. It also causes increase in lipogenesis in the liver. So fat storage in the liver can cause non-alcoholic hepatic fatty liver or hepatic steatosis. So which is one of the feature with PCOS, especially it's a long-term problem. So hyperandrogenism can cause hirsutism and acne. So these are the clinical manifestations of hyperandrogenism. So if you look at this picture on the left side, this is the HPO axis, hypothalamo-pituitary ovarian axis. So dysfunction of this can cause increased secretion of LH. So LH, you all know, it acts on the theca cell. So theca cells produce androgen. So aromatase is actually it's an enzyme which is in the granulosa cells. So it converts androgen to estrogen. Normally, the ovaries will be rich in androgen and it will be balanced. It will be rich in estrogen and it will be balanced. However, with PCOS, what happens is the androgen levels are in excess because of hypersecretion of LH, and so the follicles are arrested in different stages of its development. That's why we see it as a polycystic ovaries, and it can cause anovulation, resulting in menstrual irregularity and infertility. Again, it's because of anovulation. So another interesting theory which was put forward in 2012 by Pierce and Tremelin is dogma theory. This is a dysbiosis of gut microbiota as a cause of metabolic and reproductive features of PCOS. So this is explained in this diagram. So this picture explains the diverse spectrum of presentation with the PCOS, which is a challenging thing for the healthcare provider to diagnose. So it is a heterogeneous condition, presenting with, you can see, from low BMI to high BMI. So this table shows the diagnostic criteria for PCOS. It has evolved from the time of Steen 11th time, and the current recommendation is the International Evidence-Based Guideline for the Assessment and Management of PCOS 2018. This endorses Rotterdam's criteria. So what is Rotterdam's criteria? Actually, Rotterdam's criteria was put forth in 2003. So there are 3 clinical features which is very important in the diagnosis of PCOS. Any 2 out of 3 must be satisfied. So international guidelines accept Rotterdam's criteria for the diagnosis of PCOS in adult. However, in adolescent, it doesn't include ultrasound as a criteria in the diagnosis of PCOS. So it says a strict criteria must be followed. That is, to identify PCOS, the adolescent must have both the features like hyperandrogenism and menstrual irregularity. If they have only one feature out of this, so you have to consider them at risk or increased risk, and you have to arrange for further follow-up. So Rotterdam's criteria includes 3 clinical features, out of which 2 must be met, any 2. So the 3 clinical features are hyperandrogenism, a menstrual abnormality. So you can say ovulatory dysfunction. Oligomenorrhea means a decreased frequency of menstruation. So it can be either oligomenorrhea or amenorrhea. And polycystic ovarian morphology. So any 2 is necessary to diagnose as PCOS according to Rotterdam's criteria. This was by Esri and ASRM. And National Institute of Health evidence-based methodology workshop in 2012, it also endorses Rotterdam's criteria, and it insists phenotype identification of PCOS for research. So what is this phenotype in relation to PCOS? There are 4 phenotypes identified in PCOS according to the clinical features mentioned here. If the patient has all the 3 clinical features, that is phenotype A. If she has only the first 2 clinical features, phenotype B. If for a phenotype C, the first and last clinical features are included, and phenotype D, it is the last 2 clinical features. So to know further about the importance of the phenotypes, there is a Venn diagram. You can see the Venn diagram, including the 3 clinical features: hyperandrogenism. Hyperandrogenism is manifested as hirsutism, acne, alopecia, or seborrhea, and menstrual abnormality due to ovulatory dysfunction can also present with subfertility and endometrial hyperplasia because of unopposed estrogen stimulation of the endometrium, because no ovulation, so no progesterone, so endometrium is not protected, resulting in endometrial hyperplasia. So this can be a spectrum from simple, complex to atypical, and sometimes atypical hyperplasia can coexist with endometrial malignancy, which is a serious condition. And the other third clinical feature is polycystic ovarian morphology. So what is the importance of this polycystic ovarian morphology? Actually, it's the follicle. It's not a cyst, because it was arrested in its development due to androgen excess. So this ovary, if it is stimulated, that is ovulation induction is done for infertility, it can cause ovarian hyperstimulation syndrome. This is especially important to consider in infertility treatment. So if all the 3 features are present, or only the hyperandrogenism and ovulatory dysfunction, then it's classic PCOS. If she has ovulatory dysfunction and polycystic ovarian morphology, then that is non-hyperandrogenic type of phenotype. The last one is the ovulatory type of PCOS. So let me discuss in detail about the 3 clinical features which is important in the diagnosis of PCOS. First is clinical hyperandrogenism. What is hirsutism? Hirsutism is the male pattern of hair growth in the female. You know, definitely none of the women, they like unwanted hair growth. So how to identify whether it is really pathological hirsutism? How to differentiate from vellus hair? So it is a terminal hair which is pigmented and thick, and it will be more than 5 millimeter if it is not cut. So, you know, when you are assessing a woman, you have to ask a thorough history and perform physical examination for hirsutism, because they might have undergone cosmetic procedures. So it may not be apparent. So you need to ask the patient and also find out whether it is bothering her, because it is one of the cause for negative impact and it can affect the quality of life. So this is assessed by standardized visual scoring, modified Ferryman-Galway score. So if it is 4 or more than 4, it is indicated as hirsutism, but note the patient's ethnicity and also age. So other clinical manifestations are alopecia. For alopecia, we advise a Ludwig's visual score to assess the degree and distribution of alopecia. You can see the different gradings here. It's a pictorial assessment. However, for acne, you know, in adolescent, it's normal pubertal transmission to get a comedonal acne. So it should be included in the diagnosis only if it is severe inflammatory acne or severe comedonal acne. That is more than or 10 or more than 10 pimples on the face. The acne, so that is called the pimple. So you can see how it can have a negative impact on the adolescent girls. Okay, so but alopecia is not included in the diagnostic criteria in adolescents. Next is biochemical hyperandrogenism. So when she has no clinical features of hyperandrogenism, the next step is to find out whether she has biochemical hyperandrogenism. So serum free testosterone and free androgen index can be advised, but you need to use a standardized assay for accuracy of the result and also for the reliability. So international guidelines advises mass spectrometry and also liquid chromatography in the assessment of hyperandrogenism. So how to assess irregular cycle in PCOS? So if the woman has any of the following menstrual pattern, it is considered abnormal. So you know, in the first year post-menarche, it's normal to have irregular menstrual cycles. It is because of immaturity of the HPO axis. However, after that, usually it will regularize. But if the woman has PCOS due to ovulatory dysfunction, it may not be normal. So 1 to 3 year post-menarche, less than 21 or more than 45 days, more than 3 years of post-menarche to perimenopause, less than 21 or more than 45 days is considered abnormal. Or any period of time, if the cycle length is more than 3 months, that is also abnormal, which is a diagnostic criteria for PCOS. So another picture I have included here to show how the insulin resistance can manifest. This is the first picture is the Acanthosis Nigrikens, which is a sign of insulin resistance. You can see this as a pigmented, thickened skin, usually on the nape of the neck. And also it can be seen in flexural areas like axilla, groin, and inframammary areas. So this is called Acanthosis Nigrikens. This is a marker of insulin resistance. And also if there is abdominal obesity, you have to assess with the waist circumference. And if you are measuring the waist circumference, you need to remember WHO guidelines, which is specific for the ethnicity, for the cutoff levels. The third criteria, which is important, is the polycystic ovarian morphology. So international guideline recommends using transvaginal ultrasound, and either or both ovary must have total follicle count in each ovary more than 20 follicles measuring 2 to 9 millimeter, and or ovarian volume of 10 ml or more. So this is classically seen by ultrasound as a string of pearl appearance with a hyperechogenic stroma in the middle. So these are the follicles which are arrested because of androgen excess. So the international guideline also recommends ultrasound should not be used in the diagnosis of PCOS in adolescents in less than 8 years after menarche because of multifollicular ovaries, which is physiological. I think Prof. Kareem will be discussing more about imaging, so I am not touching on that. This is a laparoscopic picture showing bilateral polycystic ovaries. You can see the ovaries are enlarged and it looks polycystic. So you can see the uterus looks normal. This is the posterior aspect, and you can see this is the pouch of Douglas. And this is the fallopian tube with the fimbrial end, and these are the uterosacral ligament. These are the, so that is the anterior aspect of the uterus. The bladder will be here. Okay. So how to diagnose PCOS? So we follow Rotterdam's criteria to diagnose PCOS in adults. That is 2 clinical features out of 3. However, in adolescents, the first 2 clinical features, the clinical hyperandrogenism and ovulatory dysfunction, must be present for a clear diagnosis of PCOS. However, if only one is present, remember, you have to consider her at high risk and you need to reevaluate her later. Also remember, PCOS is a diagnosis of exclusion. So you need to rule out other causes which can mimic this condition, like thyroid disease, hyperprolactinemia, and also congenital adrenal hyperplasia, which can be late onset, and Cushing syndrome, adrenal tumors or ovarian tumors which secrete androgen. This should be excluded with respective investigations. So why we are concerned about PCOS? You know, it's mainly because of the long-term consequences. If you diagnose it timely and intervention is also done timely, then you can prevent this consequence. So mainly metabolic syndrome. It can cause ischemic heart disease, hypertension, pre-diabetes, type 2 diabetes, and dyslipidemia, obstructive sleep apnea, and endometrial malignancy. And there are also issues with infertility because of anovulation. Even if a woman conceives, there can be adverse obstetric outcome like recurrent miscarriages, or can have gestational diabetes and also preeclampsia. It's very important to monitor during pregnancy for these problems. So how to assess for these risks? First, cardiovascular risk assessment should be done periodically, the minimum 6 months to annually, depending on the patient's risk factors. So anthropometric measurements must be done, and remember, it should be you should follow the WHO guidelines, and the cutoff should be ethnic specific and also age specific, especially for the adolescents. And blood pressure should be monitored regularly, also fasting lipid profile. So risk factors can be smoking, obesity. You need to address all those. Glycemic status also must be monitored annually to 3 yearly, depending on the patient's risk. If she is from a high-risk group, that is strong family history of diabetes, or BMI is on the higher side, in Asians, 23 or more than 23 is considered as overweight, you can advise oral glucose tolerance test. And during pregnancy, at the time of booking, and also between 24 to 28 weeks, OGTT is a must. Then obstetric and obstructive sleep apnea must be screened using the proper questionnaire. Berlin's tool is used. And endometrial cancer is one of the serious problem which can occur in PCOS. So when to suspect this condition? If a woman has prolonged amenorrhea, or she presents with erratic heavy bleeding, or if she has any risk factors like PCOS risk factors like high BMI. So in those cases, you have to check the endometrial thickening by transvaginal ultrasound. If there is persistent endometrial thickening, you need to advise endometrial biopsy. So the pragmatic approach to prevent progression to endometrial cancer is cyclical progestrogens. You can use cyclical progestrogens if she doesn't get her cycles in 3 months, or if she wants contraception, you can advise Mirena, which is levonorgestrel releasing intrauterine therapeutic system. So this is the WHO guideline for the BMI category and for the waist circumference. You have to follow these cutoffs. Another important thing is you need to address the psychological features in PCOS. You know, this is not included in the diagnostic criteria. However, the clinician must exercise his judgment to find out this. And if you screen and identify she has any of these psychological features, you have to promptly refer the patient for further management. So it's very important to take care of the emotional well-being of the women. So definitely there are studies which have shown that it has poor scores associated with the quality of the life of PCOS women. So how to treat women with PCOS? You have to focus on the patient's concern. So what is her primary problem? So, and you need to discuss with the patient first about the diagnosis, and you have to take into account about the psychosocial and cultural factors, and also patient preferences. You know, there is sometimes social stigma associated with obesity. So you need to take this all into concern, and also the patient's age and a need for contraception. So mainstay of management is lifestyle modification. So our aim is to achieve weight reduction. So weight reduction is mainly with lifestyle intervention. So this is our goal. So first prepare the patient with that what is a problem. You have to explain to her, communicate, give her appropriate information related to her problem. You must provide the resources must be available, written, audiovisual material, and also you have to discuss with the patient about it should be culturally appropriate also, and with the language which she can understand. And you have to help her to overcome these issues. We must have some strategies to work out this, and always you need to support. So you must be a respectful and empathetic carer in her whole journey of PCOS, because this is a chronic problem which she has to overcome. So these are the lifestyle interventions which are advised. Ideally, it should be the multidisciplinary care. It must be a multidisciplinary care involving primary care physician, family medicine specialist, obstetrician, endocrinologist, reproductive medicine specialist, a psychologist, and you also need to include a dietitian, dermatologist, and exercise physiotherapist, and so it should be a multidisciplinary team basically. So you have to look at the patient as a whole. You should not compartmentalize a problem. That is one of the main reasons this problem goes undiagnosed. So diet is very important. Balanced, healthy diet. So better to get advice from the dietitian. So usually we advise a low glycemic index diet and to avoid simple sugars and to use complex carbohydrates and avoid free fatty foods. So that's the basic of having a balanced, healthy diet. And if she has to reduce weight, you have to have a calorie deficit. So 30% reduction you have to advise in the energy intake. And exercise must be a structured one. So you have to advise her about the SMART goals. SMART refers to it should be specific and measurable. It must be achievable, and it should be achievable reality, and it should be timely as well. So the goal must be set, and she must have a trainer for these exercises. So it can be aerobic exercise, or which can be mild, moderate, or it can be vigorous physical activity. Slowly she can increase her exercise capacity, and for to achieve a weight loss, actually she has to do about 90 minutes of exercise, moderate physical activity per day. However, if she has to maintain her weight, 30 minutes of physical activity, moderate physical activity per day is advised. So how does it work? The lifestyle intervention. Lifestyle intervention works because it decreases the insulin resistance. When the women exercises, the insulin uptake by the adipose tissue, muscle, so all this will be improved. So the insulin sensitivity is improved, so it can help in weight reduction. So behavioral strategy plays an important role. So it can be done concurrently with the other lifestyle intervention, cognitive behavioral therapy especially, because this can encourage and motivate the woman in her journey through the weight loss. So she has to be motivated to maintain the weight loss. So aim is to reduce the weight by at least 5 to 10%, so that it can definitely have impact on the ovarian function. That is, she can resume her menstrual cycles and can have ovulation, and she can get pregnant as well. And she also will feel good about it, and it can improve the quality of life. And it will definitely have also effect on the androgens. It can decrease the androgen levels. So what are the pharmacological treatment available with PCOS? So if she has menstrual irregularity and hyperandrogenic issues, then you can advise combined oral contraceptive pill. That is the drug of choice. However, if combined oral contraceptive pill is contraindicated because of absolute contraindications like ischemic heart disease, hypertension, or thrombophilias, long list of contraindications, you have to rule out that she has no contraindication. And also, if she cannot tolerate combined oral contraceptive pill, then you have to advise metformin. So for hyperandrogenic features, you have to advise cosmetic therapy along with this. So it will take about 6 months to 1 year for the cosmetic therapy, for the combined oral contraceptive pill to show its effect related to hirsutism. So other cosmetic treatments which are available are electrolysis, photolysis, and laser. To have a quick response, you can also advise eflornithine topical cream. It has to be applied twice daily. It acts on the follicle by inhibiting the ornithine decarboxylase. So it will take about 12 weeks for it to show its effect. However, if this cream is applied, there is a risk of thinning of the skin, and you need to advise the women to use a UV cream, which has a larger range when she is working under the sun. And these androgens, anti-androgens, are used only as a second line. If she is not responding to the combined oral contraceptive pill, then you can consider anti-androgen. The main problem with anti-androgen is you need to advise contraception, because if not, if she gets pregnant, it can cause under-virilization of the male fetus, or you can say emasculation of the male fetus. So cyclical progesterone usually is advised every 3 months for endometrial protection. So when you are prescribing combined oral contraceptive pill, usually we advise low dose estrogen, which is 20 microgram of estrogen along with the progesterone, which has anti-androgenic properties. So how does this work? Combined oral contraceptive pill causes suppression of the gonadotropins. So it causes suppression of LH. So suppression, hypersecretion of LH is involved in the pathophysiology. So suppression of LH will cause ovarian suppression. So that's how it also increases the sex hormone binding globally. So in turn, it decreases the free androgen levels. That's how it's effective in improving the acne and hirsutism. We can consider anti-obesity agents. There are some anti-obesity agents which are available in the market, but you need to consider this only if lifestyle intervention doesn't work in a BMI 35 or more than 35. So orlistat, sibutramine, but you need to discuss with the patient about the cost effectiveness and also what are the adverse effects associated with anti-obesity agents. So definitely contraception is a must. Then about inositol, it is an experimental therapy. It's a supplement. It's a second messenger and it acts as an insulin sensitizer. So it can be used as an experimental therapy. The last one is the complementary therapy. So some people find that they are happy with the complementary therapies like acupuncture or herbal remedies, then you can continue with that. So how to treat infertility? So even in infertility, the first line of management is lifestyle intervention. British Fertility Society guidelines advise not to start oral ovulation induction agents unless the BMI is less than 30. So with lifestyle intervention, you have to bring down the weight so that she has optimal BMI. So first line pharmacological management for PCOS are letrozole, clomiphene. You can use clomiphene citrate with metformin and metformin alone. In some cases, you can consider gonadotropin. So how does letrozole work? Letrozole is an aromatase inhibitor. So advantage of letrozole is it's unifollicular ovulation. So only one follicle will be developed. So there is low risk of multiple pregnancy and also ovarian hyperstimulation syndrome. But clomiphene, there is risk of multiple pregnancy and also a small risk of ovarian hyperstimulation syndrome, which is less than 1%. And if the woman is as metabolic risk like BMI is more, then you can add metformin. So metformin, because it's an insulin sensitizer, it will further improve the pregnancy outcome. I mean, it can increase the pregnancy rate and the live birth rate. The second line of pharmacological management is advised if there is a clomiphene resistance or clomiphene failure. So you can ask how long should we use clomiphene? So clomiphene can be used for 6 months or up to 12 months. It depends on the hospital protocol because international guidelines, it advises up to 12 months. But you also need to remember if ovulation induction agent is used for a longer time, it's one of the risk factor for ovarian malignancy. So second line, you can use injectable gonadotropins. Injectable gonadotropins can cause multiple pregnancy and also increased risk of ovarian hyperstimulation syndrome with PCOS. So the other option is surgical induction. Surgical induction with laparoscopic ovarian surgery. Laparoscopic ovarian drilling can be advised. However, you must discuss with the patient about the risk of surgery. It's a laparoscopy. There are some associated risks like injury to the bowel, bladder, and the blood vessels. And also, there is a very small risk of decreased ovarian reserve if laparoscopic ovarian surgery is, ovarian drilling is done. So we follow rule of 4. There is a 40 watts used for 4 seconds, 2 to 4 seconds usually, 2 to 4 millimeter deep, which I'll show in the next picture how ovarian drilling is done. The last resort is IVF, in vitro fertilization. So you can see a picture of ovarian drilling which was done. You can see the 4 punctures. This is laparoscopic ovary. So each ovary, it can be 4 to 10. But if you do more punctures, you can compromise the ovarian tissue. Okay, this is laparoscopic ovarian drilling. So you can see bilaterally the ovaries are punctured. So how does it act? So this can decrease the androgen. So there will be balance of estrogen and androgen. So it can help with ovulation. So here also unifollicular ovulation. So the low risk of multiple, or you can say it's a background risk of multiple pregnancy. And you can also consider anti-obesity agents. Yes.
Yeah, we have another 5 minutes to
okay.
the session.
You can also consider anti-obesity agents before fertility treatment. Also remember, it might take time if you start these medications to optimize our BMI. And surgical management. When to advocate surgical management, which is a bariatric surgery? No. Bariatric surgery is advised if she has morbid obesity. It's a 40 or more than 40, or her BMI is 35 or more than 35, despite lifestyle intervention, and also she has at least one comorbidity like diabetes or impaired glucose tolerance, you can advise bariatric surgery. So bariatric surgery, vertical sleeve gastrectomy is preferred in the according to the international guideline, compared to gastric banding or root-sane gastric bypass. You also need to remember, if you advise these bariatric surgeries, the women will have a rapid weight loss in the post-operative period, and also there is risk of nutritional deficiencies, and you need to supplement her with the nutrition. So usually we will not advise her to conceive 1 year or 12 months after the procedure. So the delayed treatment you need to, delay in treatment of infertility, you need to take into account if you advise bariatric surgery. And also it can have impact on the pregnancy. Especially it can cause, there are studies which have shown that the fetus can be small for gestation age because of inadequate nutrition. And also there is a risk of intrauterine death. So I have 3 case scenarios. Actually, the first case scenario is an online patient which we used for our students during our e-clerking and pandemic days. So she was a 30-year-old Malay, single, unmarried. Actually, when she presented with the history of secondary amenorrhea for 1 year. That means 1 year she had no menses, 12 months race. However, she has history of acne, but no hirsutism. She said she attained menarche at 10 years, but her menstrual history has been irregular from the beginning, 3 to 4 to 6 months. And at 14 years, her mom took her for evaluation because of irregular cycle. So she was investigated for hypothyroidism and she was told to be normal. After that, she didn't go for any visits. But before 1 year, she had a withdrawal bleed after 3 months period of amenorrhea. She's not sexually active. So always you remember, you need to rule out pregnancy whenever a reproductive age woman presents with the period of amenorrhea. So she's not sexually active. Current weight is 125 kg. So what is your diagnosis in this case? Most probable diagnosis. Just type in your chat box. We'll discuss about this later. No, with great difficulty, she brought her weight to 95 kg. But during the pandemic, she gained everything back and she came back to 125 kg. So this is really sad. Another case scenario, she was a 34-year-old Indian, married 7 years. Actually, this is my friend. She's a doctor. Now she's an anesthetist. Actually, she was diagnosed with type 2 diabetes 4 years back, and she was on metformin extended release, 750 milligram. She's a known case of PCOS. Her BMI was 27, and she was investigated and treated for primary subfertility. And she had her second cycle of IVF. And she was having severe nausea and vomiting when I saw her week after her second cycle of IVF. She was very worried, and her husband was down because they couldn't sleep the whole night, and they went to nearby clinic to have IV fluids because of, she thought it's because of gastritis, because she often gets gastritis. It can be related to metformin. Metformin, the common side effect is GI side effect. So to avoid that, we use extended release, but still she has gas. So she thought it's related to gastritis. So I want you to mention the diagnosis. What is the most probable diagnosis in her case? The last scenario is a 35-year-old Malay lady, married 10 years, nulliparous. She presented with heavy, irregular vaginal bleeding for 6 months with anemic symptoms because of heavy bleeding. Again, menarche 10 years, and cycles have been irregular once in 4 to 6 months, and BMI is 33. pelvic ultrasound showed endometrial thickening. She had an endometrial biopsy because of, she was diagnosed as PCOS and underwent endometrial biopsy. It was found to be atypical hyperplasia. My question is, what other endometrial pathology you must have in mind when the histopathological examination comes out as atypical hyperplasia? So 3 diagnoses I want you to type in the chat box. We'll discuss in the question answer session. So this is my carry home message. So PCOS is a heterogeneous endocrine disorder with reproductive, psychological, and metabolic feature, and diagnosis and risk assessment is paramount because you need to diagnose at the earliest for timely intervention and prevention of further complications. So lifestyle intervention is the mainstay in managing PCOS. So our aim is to achieve weight reduction at least 5 to 10%. Always address the patient's concern. So these are my references. Thank you. If you have any questions, you can discuss during the Q&A session, or you can just type in the chat box. I'll try to answer in the chat box. Thank you.
Okay, thank you, Dr. Anitha, for the very wholesome and holistic approach to PCOS. As a key message, I think we should treat the person with the disease and not just focus on the disease. So going on to our second lecture, it will be delivered by Prof. Eugene Leong. Prof. Eugene Leong was the one who initiated the Women in Health webinar since last year during the pandemic. To introduce Prof. Leong, Prof. Eugene obtained his undergraduate degree from the Faculty of Medicine, University of Malaya, Kuala Lumpur. He was nominated by the Faculty of Medicine and awarded Association of Commonwealth Universities Medical Electives Bursary as an undergraduate medical student. He completed his housemanship at then known as University Hospital, Kuala Lumpur, and obtained training under Professor Dato V. Sivanesaratnam for his MRCOG UK in the University of Hospital, and at the same time he pursued his MOG in University of Malaya. He passed both the examinations in 1997, and he was conferred FRCOG UK by the Royal College of Obstetricians and Gynecologists, United Kingdom, and went on to do his subspecialty training in minimally invasive surgery with attachment at the Kandang Kerbau Women's and Children's Hospital, Singapore. In 2003, he was trained in the fellowship training program at the Kandang Kerbau Women's Children's Hospital, Singapore, under Professor Dr. Teh Eng Sion and Professor Dr. Jeffrey Lau for 12 months in both complex gyne-oncology surgery, gyne-oncology wards, chemotherapy, palliative care, and tumor board. He was also promoted to associate professor in the University of Malaya in December 2003. Prof. Eugene Leong is currently our Associate Professor in Obstetrics and Gynecology in Taylor's University School of Medicine, Selangor, and he is also the visiting consultant obstetrician and gynecologist at the BP Healthcare, Taman Mega Medical Center, consultant on gyne-oncologist at Sri Kota Specialist Medical Center, Klang, with clinic sessions and operating and admitting rights. He also has opened his own clinic since August 2018. His clinic is known as Klinik Paka Wanita Imperial New Life Precious Obstetrics and Gynecology at Bandar Puteri, Puchong. Prof. Eugene, we would like to welcome you.
All right, thank you very much. Can I have the slides, please? I thought I will just show a few pictures. Can we have the slides? Can you all hear me?
Yes, we can hear you. Yeah, Kuhan.
Yeah, are you all sharing the slides, please?
Yes, doctor. I'm trying to share it.
Right. Anyway, I thought I started with discussing about fibroids by just showing some pictures. This is a picture of a patient with a fibroid uterus which has been removed. The next picture, please. The next picture. Yeah, this one is a dilated tube, just for comparison. This during laparoscopy. The next picture, please. This is a fibroid. It's a fibroid that's removed intact from a patient. Next picture, please. This is another fibroid, a big and a small one, removed from another patient. Next picture, please. This is a small preview of what we see when we see a mass in the pelvis when we do an ultrasound. Next page, next picture. And this is another picture of a mass when we do an ultrasound. On the top is the bladder. And the next picture, I think we're done. Next picture. Yeah, this is another showing a cyst in comparison. Huh? All right, I think that's the last picture. Can we go on to the slides? Thank you. Okay. These are all pictures of real patients that I've seen and I've operated on. Huh? Right. Okay. So the title is I Have Fibroids and What Do We Do? So next one, next slide. Now, in this month, October 2021, I operated on 3 different women with fibroids. And out of the 3, one turned out to be a cancerous fibroid called leiomyosarcoma. Of course, for patient confidentiality, I have changed a few characteristics to anonymize the features. She's married, she has children, she had pain, she had persistent pain with the fibroids. And that was what brought her to see for opinion. And she even somewhere along the way had severe pain and she had to go to see a general practitioner with severe pain. And she was counseled, discussed. Pre-operative bloods were all normal. The cancer markers were not elevated. And she wanted to have the uterus removed, but to preserve the ovaries. After that was done, the report came back that it was a cancerous fibroid. Next slide, please. In February this year, I saw another patient who is age 42, 3 children, also had fibroids with pain. And she was referred to me. And after doing the operation and everything and doing all the scanning, we found that she had a leiomyosarcoma, a cancerous fibroid, which was metastatic, that was invading the lungs. And she has been on chemotherapy. Next slide. Next slide, please. Okay. So how many women in the world have fibroids? According to the National Institute of Health, it is estimated that 40 to 80% of women will develop fibroids some point in their life. And the most common age is in the late 30s, 40s, and late 40s. Now, when they look at the hysterectomy specimens, 77% of women have fibroids, generally speaking. And African American women have a higher incidence of fibroids, and fibroids increase with age. And fibroids can cause many things: heavy periods, pressure, pain, irregular bleeding, anemia, lack of blood. And another issue is because it happens so often in women, it can happen that you are discovered to have a fibroid when you're pregnant, and they have other implications. One of which is preterm labor and recurrent miscarriage. Next slide, please. So what do? If you went for a routine check and a scan done at any clinic and they found that you got a small fibroid, maybe it's very small, 3 millimeters, 5 millimeters, or 1 centimeter, or very small, no less than 4 cm. Very often you don't do anything, but certain tests need to be done. The next slide, please. Now, what if it's big? You can even feel it yourself. It's as big as if you're pregnant 4 months, or it's as big as if you're pregnant 6 months. The biggest I've operated on was about a 15-kilo fibroid in a 30-something-year-old lady, a 15-kilo fibroid. So it's a huge one, fill the entire stomach. Next slide, please. Next slide, please. So fibroids can also be single or multiple. If it's single, means only one fibroid. If it's multiple, means it's a number, it's like a bunch of grapes. And they often come multiple. Usually it doesn't come as single. Once in a while it does. Next slide, please. Next slide. So the fibroid can be on the uterine surface, which is called a serous fibroid, subserous fibroid. It can be inside the uterus, which is intramural, means inside the uterus. It can be submucous, that means it's inside the uterus, but it's just below the lining of the endometrium where your period comes every month. And you can have a small 2 cm fibroid that is submucous, and you can have a lot of bleeding due to this small fibroid. Next slide, please. Another category of fibroid is a broad ligament fibroid, which I've seen a couple and operated on many. It is between the leaf of the broad ligament. Now, as I said before, fibroids can cause irregular bleeding. It can come as a huge lump or mass. It can cause very heavy bleeding. Your HB or hemoglobin can drop to 5 gram percent or 6 gram percent. And some people just complain that they can't wear the jeans, or it's very heavy and you feel as if the stomach is bulging. Next slide, please. So fibroid can be in patients with nothing. They are very well. They don't even know they got fibroid. They've got normal periods. They got no pain. They when they do a blood test, it's all normal. So that can happen. They are asymptomatic. Next slide, please. Next slide. Okay. Now, what happens if the fibroid keeps getting bigger? It's bigger and bigger and bigger. Every time you scan, it's bigger by 1 cm. Every time you scan, it gets bigger by 1 cm. And the bleeding gets heavier and heavier. Then you need to do something with it. Okay. Of course, many women, if given a choice, they don't want anything done. They would rather just wait and see. They don't want anything done. And there are many women who don't want anything done. Next slide, please. Now, what do? If you do a cancer marker test and the cancer marker test is very high, say it's 500, does it mean it is cancerous? Unfortunately, the cancer marker is not very accurate. Even with a cancer marker of 500, it doesn't mean it's cancer. On the other hand, if the cancer marker is 10, it also doesn't mean it is not cancer. The final thing comes when you remove the fibroid and you send it for testing in the lab. Next slide. So I will just give a little bit of patient scenario to so that we can see what we do see as a doctor every day in life. Next, please. Next slide. Okay, this is Madam Alice, 37 years old, 3 children. Youngest child is 8 years old, has been using contraceptives, and she has got no problems. Then she goes for a routine annual medical and found 3 fibroids. And the size not that big, 5 cm, 4.5 cm, 6 cm. Cancer marker is slightly high, 65. The hemoglobin is marginal. What do we do? So there are many things to consider. All right, let's go to the next scenario. The next scenario. Okay. Madam Virginia is 45 years old. Her mother died of ovarian cancer. She's single, no children. She's a huge mess there. 20-week size. 20-week size means they are 5 months, almost like 5 months pregnant. She's got heavy periods, there's pain, there's spotting, there's pelvic heaviness, and somebody told her that she requires the womb to be removed. Then she is deliberating, should I keep the ovaries? But the mother had ovarian cancer. So these are the things that we come across every day in our practice. Next one, please. So Madam Pearl, 41 years old, younger, 2 children. She has been diagnosed with a fibroid, but this fibroid is growing. It's growing. In July 2020 is 4 cm. In July 2021 is 22 cm. HB is low. She's got some pain. The cancer marker is very high, 900 something. And the chest X-ray shows a nodule in the lung, and the kidney is dilated. So it's a different subset of fibroids. Next one, the next slide, please. So I saw a lady many years ago, a 36-year-old lady with 3 children, and she had 2 lung nodules on the CT scan. It was huge fibroid. It was about almost like 26, 28 week size. And because of the lung nodules, she was considered as stage 4 for cancer of the fibroid. Nobody wanted to operate on her because traditionally we don't operate on stage 4 patients. But she was very well, and she was very young, and she had 3 young children with her. So despite the fact that we don't operate on stage 4 masses, but because it's so huge, and we felt that after discussion with family, it's good to remove the primary so that she will not get more and more secondaries. So we decided, after counseling and discussion with the family, to assemble a team. We spent about 8 hours to remove the primary tumor, and after that, she had chemotherapy, and she survived for another 2 years. She also, along the way, went off to Taiwan to have some herbal treatment in Taiwan. But that is the cancerous form of fibroid. Next slide, please. So unfortunately, size of fibroid alone doesn't tell us much. It doesn't tell us whether it's cancerous or benign. You can have a very big fibroid, but it's not cancerous. You can have a very small fibroid, as small as 1.5 cm, and it can be malignant. And I've seen this before. There was a patient whom I saw with a 1.5 cm fibroid, and she kept going to the toilet every night to pass urine a few times. She couldn't tahan, you know. So in the end, she decided to get the gynecologist to operate on a 1.5 cm fibroid. And that came back as a cancerous fibroid. And by the time I saw her, she was referred to me. It had spread to the lungs. She survived another 1.5 years. She was in her 30s, late 30s. So size doesn't tell you whether it's cancer or not, whether it's 1.5 cm or 10 cm. Next slide, please. Now, location of fibroid. Location of fibroid also is important. As I said, it is submucous, just below the lining of the womb, which the period comes every month. The bleeding can be a lot. It can be in the cervix. It could be coming out from the cervix. It can be near the bladder, which causes the person to go to the toilet at night every 3 or 4 hours or 3 or 4 times a night. It can also cause the intestines to be sticking to the fibroid and causing intestine problems. Or there could be other things as well, endometriosis or some ovarian cyst or something else. All right. Okay, next slide, please. Next slide. Okay. So as usual, we need to make sure she's not pregnant. Although some patients will say the period just came 3 weeks ago, we need to make sure she's not pregnant. And we need to make sure there is no issue with the fibroid. Is it cancerous or not? Is there any recurrent miscarriage or not? Is there any infarction? That means when the fibroid gets bigger and bigger and bigger and bigger, the blood supply to the fibroid becomes not enough for the fibroid. So when that happens, the fibroid will get infarcted, means certain parts will die because the blood supply is not enough for the fibroids. Keep growing, keep growing, keep growing. Next slide, please. Now, so when we see a patient with fibroids, what are the things that tip our surgeon's hand that make us say, well, maybe you should consider removing the fibroid? When it's pain, when it's growing very, very fast, from 2 cm, it becomes 5 cm, from 5 cm, it becomes 8 cm. When the cancer marker is very high, I'm not saying it's 79, we're saying it's like 200, 300, 400. If she has got a lot of coughing and you can't explain why she's coughing, and when you do imaging, there's some probable secondaries in the lung. If it's already so big, the fibroid is sitting on the ureter and is causing backflow of urine to the kidney with dilated kidney, when there's unexplained fever, when there's persistent bleeding, when the pap smear is not normal due to other issues, and for example, there are other things like there's a huge ovarian cyst or recurrent miscarriage, then that will make us decide, look, I think maybe you should consider removing the fibroid. Next slide, please. Now, once in a while, we see a patient with a big fibroid who cannot pass urine. They just cannot pass urine because the fibroid is at the critical point that is the kachao, the urine part of the system. It's called an incarcerated fibroid. So we need to put in a catheter. She needs to be in the hospital for 2 days, 3 days, just to let the urine come out and to relax back the urine system so that she can pass urine. And this can also happen in somebody with a fibroid post-delivery of a baby. Next slide, please. Now, some patients have a fibroid polyp. That means there's actually a fibroid that is by 4 or 5 cm that is coming through the os like a small baby coming out. And it causes irregular bleeding. They get bleeding after sexual intercourse. They get pap smear abnormalities. But if the doctor doing the pap smear didn't look carefully, they will have missed the fibroid. And this fibroid can get infected. And you will have a smell. You may have a really bad smell all the way. And then you didn't know what's the reason. Then when you check properly, there's a fibroid there sitting in the vagina, coming out from the cervix. Next slide, please. Okay. So suspicion of cancer, that is a very, very overriding concern. Next slide, please. Next slide. Okay. Okay, we mentioned just now about a non-standard fibroid. What is a non-standard fibroid? A non-standard fibroid is something that is in a subclass by itself. You have got something called cellular leiomyoma. You have got a stump, smooth muscle tumor of unknown malignant potential. So fibroid alone, when you say fibroid, it can mean cancerous, it can mean normal fibroid, it can mean cellular leiomyoma or stump. Some of these things can be one of those kinds of fibroid. So as I mentioned earlier, if it's fast growing, it's very large, irregular, there's pain. It feels very hard when you examine it, very hard and irregular. When you do a vaginal examination, it is fixed. It cannot be moved. It is fixed to the surrounding tissues. And she has got bleeding, and the cancer markers may or may not be elevated. So these are the warning points that, look, it is time to do something. Next slide, please. Next slide. So non-standard fibroid, we just mentioned it, right? Next slide. Next, sir. So there's something called intravascular Lyomyomatosis. This one is a very funny one, where the fibroid is actually not cancerous, but it grows and grows and grows and follow the blood vessels. And it can even go to almost to the lung. It's called intravascular Lyomyomatosis. And they present with very funny symptoms. And they need a CT scan to see these small fibroid growing like a snake along the blood vessels. Not common, but we've seen before. Next slide, please. Next slide, please. Okay. So everybody will say, doctor, what if I don't want to operate? Are there any possibilities not to operate? All right. Yes, there are. You can give GnRH analogs like Lucrine or Zoladex. You can give anti-progestogens. You can do HIFU. HIFU is an ultrasound kind of thing that can help to reduce the size of the fibroid. You can also use uterine artery embolization, but they all have their pros and cons, right? They all have the pros and cons. There's no magic. Next slide, please. There are some patients with a 1 cm fibroid, 2 cm fibroid say, doctor, can I just come back and scan back in 6 months' time? Of course you can, right? Do the basic things first. Do the pap smear, do the cancer marker, do an X-ray if you feel you really need to. You may want to do a CT scan if it's sizable, say it's 5, 6 cm, and a few other tests. Next slide, please. Now, what is HIFU? HIFU is high frequency focused ultrasound. This actually was developed in China. And the only problem is there is no specimen. You could be doing HIFU on a cancerous fibroid and it shrink a bit, so you're very happy. And you're carrying this not good fibroid all along, all the way for the next 2-3 years, thinking that it has shrunk, no need to do anything. So the problem is there is no histopathology. There's no way to know it's a good fibroid or bad fibroid. Although the incidence of bad fibroid as cancer is very low, it's 0.1% to 0.5%, maybe even lower than that. But if you are the one with the 0.1%, wow, it's very bad. Okay, next slide, please. Next slide. Now, uterine entry embolization can be done. It's part of interventional radiology, where they block the blood vessels to the fibroid. So the fibroid will die. When the fibroid dies, what happens? It becomes black, it becomes smelly, and you get a very bad vaginal discharge from the vagina because the fibroid is dying. And you can go on for 6 months to a year. I've seen a patient with uterine artery embolization. After 2 years, she's still having a bad smell coming out from the vagina. And the thing is also, you don't know whether it's a bad fibroid or not because it's not been removed. And you can also accidentally cause a premature menopause because the things they use to block the blood vessel can accidentally go to the ovaries and block the ovaries. And you can get a menopause, which you didn't intend to have in 10% of the time. And after that, you cannot get pregnant if you do this uterine artery embolization. Next slide, please. So GnRH analogs is an injection, which you can shrink the fibroid, but actually the shrinkage is very low. One injection can cost 400, 500 ringgit. The shrinkage can be only 10% or 15%, and it's temporary. And it can cause osteoporosis and menopause at the same time, but the more worrying one is the osteoporosis because it blocks the hormone that support the fibroid and makes you menopause for that time. But once you stop the injection, the fibroid will grow back, and you can only use maximum of 6 months. So it is temporary. Sometimes we use this to stop the bleeding and to reduce the fibroid so that we can operate. This is a temporary measure. It's not permanent. Next slide, please. Okay, anti-fibroid medicine. Yes, it exists, but they discovered recently that it causes liver problems. And it's not cheap. It's about 600, 700 ringgit per month. And it's not guaranteed to work all the time. So again, we do not know whether it's a bad fibroid or a good fibroid. We can give it. It's available in Malaysia, but because of this reported liver problem, not many people dare to use. Even if we give to the patient and we tell them, they say, oh, liver problem. They say, never mind, doctor, I don't want. All right. Next slide, please. Okay. Now, when we look at a patient with a fibroid, we cannot just look at the fibroid. We also need to look at the surroundings, whether she's well, she got hypertension, she got diabetes, or whether she's got any other issues. We need to look at the lining of the womb, because not everybody with a fibroid who comes with bleeding has only got a fibroid problem. Maybe she got endometrial hyperplasia, maybe she got endometrial cancer, maybe she got some other issues which we cannot miss, because we don't want to remove the fibroid and end up with another problem. So careful assessment is required. Next slide, please. We also need to look at the cervix. Very often the patient has got some other issue with the cervix. Maybe she has got CIN1, which is a precancer. Maybe CIN means cervical intraepithelial neoplasia. It's a precancer. No? Is there any polyp there? No? Right? Is there any endocervical disease? Sometimes the cervix consists of two parts. One is the outer cervix, one is the inner cervix. The outer cervix we can see with the naked eye when we do a vaginal examination, but the inner cervix we can't see. It's beyond what we can see. It's inside, like the nose, the outside nose and the inside nose. So we need to assess this, because all this will help us to decide whether the patient can keep the uterus. Next slide, please. Also, we need to look at the ovaries, because very often, maybe in about 30% of the time, they got an ovarian cyst. Whether it's big or small, the cyst can also be a good cyst or a bad cyst. So you can have a patient with a cyst, ovarian cyst, as well as a fibroid. And they are very common. They come hand in hand, so we cannot ignore it. We have to look at all these things. So we need to look, and we also need to do the checking for the ovaries, the cancer marker, the scanning, the features of the ovary. Is it look like a benign ovarian cyst, or does it look like a not good cyst? Next slide, please. So very often, after looking at everything and looking at the overall picture of the patient as to whether she's stable, she's not stable, whether the cancer marker is high, whether she can accept the fact that if we remove the fibroid alone and the fibroid come back as a cancerous fibroid, we need to operate again. But there are some patients who definitely do not want the uterus removed, maybe because of many other issues. Maybe they want to have some more children, maybe they are still highly sexually active, so they want the uterus not to be removed, provided the pap smear is normal, the scan is normal, the cancer marker is not high, the pap smear and the cervix looks normal. So yes, we can remove the fibroid. The pictures that I shown you earlier, before I started the lecture, some of them showed you the mass that is removed. That is a fibroid, and we kept the uterus. Of course, the common question is, will the fibroid come back? Of course, there is a chance a fibroid can come back, but usually it will not happen so fast. Maybe 4 years, 5 years, maybe 6 years. So if you're 49 and you want to preserve your ovaries, if you're 49 and you got fibroids and you want to preserve your ovaries and your uterus, and the rest of the tests are negative, by the time the fibroid should come back in 4, 5, 6 years, maybe you're menopause already, but you still keep your uterus. So that is the advantage of doing a myomectomy, just to remove the fibroid. Of course, there are certain patients who say, doctor, I don't want anything else. I want to remove my uterus, full stop. And there are some patients who say, look, doctor, take out everything, the uterus and ovaries. I enough already. Okay, so depends on the patient and depends on the circumstances. Next slide, please. Now, there are many patients who request us to do laparoscopic surgery for the fibroid, but there's been a recent US FDA advisory that says that doing laparoscopic surgery for fibroid, where you need to break the fibroid, to juice it up, so to speak, so that you can take out the fibroid. Say you got a 7 cm fibroid and you want to do a keyhole surgery, and a keyhole surgery is only 5 millimeters. How to remove? You have to break up the fibroid. The story is like this. There was a doctor's wife who had fibroid in the US, and they wanted a keyhole surgery, which they did, and they juiced the fibroid And what happened was 2 years later, she had cancer from the fibroid all over the stomach inside. And that was because the fibroid that was removed initially with keyhole surgery was not a good fibroid. They didn't realize it. And after that, she had to undergo chemotherapy and all that. Whereas if you do an open surgery, you can take it out one whole thing, even if it's a 10 cm fibroid, without breaking it up. And there's less risk of dissemination of things. So the US FDA does not encourage laparoscopic myomectomy. And the doctor should be honest enough to tell you it is not encouraged, even in the US. Even with a tissue bag, there will still be some amount of spillage. Next slide, please. Next slide. So if you have fibroids and you have difficulty to conceive, should you remove the fibroid? That is another big issue. And that is another lecture altogether as to when you should remove. Or maybe it doesn't matter. You can carry on with your IUI or your IVF or things like that, you know. So it depends. We need to assess and individualize the management for each patient depending on the circumstances. Next slide, please. So when we have somebody who's got fibroids and married 7 years and trying to conceive, before we say, look, you need to remove the fibroids, or we say, look, you can keep the fibroids, we need to see what is the cause of the subfertility, right? We need to see what is the cause. Is there an ovulation problem? Is there the fallopian tube is blocked? Is it because the husband's working in Penang and the wife is in KL? Or that's why the timing of the intercourse is not good? Or is it because there is something that the baby can fertilize but cannot grow? Is it a sperm? So we have to look at it. What's the reason? Before we can blame it all on the fibroid. And then we say, look, you need to remove the fibroid. Next slide, please. Next slide, yeah. So there's also a big question, you know. If somebody has conceived 2 times and then she got miscarriage and she happened to have a fibroid, is it due to the fibroid? Or is it just bad luck? You know? Or maybe you didn't pray hard enough. So again, we have to look at the patient, we have to individualize the treatment, and then we have to assess carefully each and every factor before we can advise the patient. Of course, if the patient already had 3 miscarriages and it's a big fibroid, let's say it's a 7 cm fibroid, then needless to say, that fibroid probably needs to come out before the 4th pregnancy. Next slide, please. Next slide. So again, with recurrent miscarriage, just like fibroid and trying to conceive, there are many, many tests to do to rule out all the other reasons for the miscarriage before we can say, look, this is your problem, this is what you need to do, and this is in your best interest. And I would do the same if this was my wife with a recurrent miscarriage. So we have to look at all these things. Why so many tests? Because now with new technology, these tests are available. Unless we are practicing medicine 100 years ago when the tests are not available. And it will not be good for us to advise you to operate without doing these tests because the fibroid may not be the reason. Next slide, please. So if you've got a fibroid and you happen to have discovered it in pregnancy, many things to consider. And if you happen to have discovered a fibroid when you went for a routine, health check somewhere, need to look at many things. Next slide, please. Okay, thank you. I think I will be happy to take any questions later in the Q&A. I'd like to thank the people who have helped me in all these lecture series. And there are many more who I'm not able to name. Thank you very much. Thank you.
Thank you,
Thank
Prof.
you.
Yeah. Thank you, Prof. Eugene, for your very informative session. Any questions, you may drop them in the chat box, or you can also directly ask Prof. Eugene at the Q&A session later on. Moving on, our next speaker is Prof. Dr. Abdul Kareem Mira Mohideen, who will be talking on the role of imaging in the diagnosis of polycystic ovarian syndrome and fibroids. Actually, he has a very illustrious and extensive CV. I will not be doing any justice by doing this short, concise summary, but I would just try my best to highlight some of his rather remarkable achievements in his very illustrious career. He has been a radiologist for the past 43 years and has been teaching for the last 41 years. He has received numerous awards for both his academic achievements and professional recognition, including as being appointed as a senator, coordinator, school program committee, and also a GCP trainer. He also has multiple researchers that has been recognized nationally and at international levels. He has had a total of 310 scientific papers with a H index of 22. He has also delivered multiple keynote speeches and addresses, has been invited to journal review and editing. He has also supervised and examined multiple theses, and he has had trained 6,050 students in his extensive career. He is also the editor reviewer in multiple journals and also membership and fellowship in multiple organizations. He also is an internal and external unity examiner, totaling about 50 over universities, and he has multiple community service contribution and has received multiple awards for it. Actually, the list is very long and time does not allow me to actually highlight all of his achievements, but we have a very, very experienced speaker. So Prof. Kareem, we would like to invite you to deliver your talk, please.
Thank you very much. Thank you very much, Dr. Ponnupillai. And I'm very much privileged to be here to address this gathering. In fact, this is an interesting topic, and Prof. Eugene and our dear Dr. Anitha has extensively covered and made easy my job. Are you able to see my screen, please?
Can see now, Prof.
Yes, we are able to see it. Yes.
Yes?
Yes, yes.
Okay, thank you. Yeah, so the topic is very, very interesting and very useful for all of us. Whether the imaging is useful to diagnose two important conditions like polycystic ovarian syndrome and fibroids. If you are able to diagnose by imaging, is it valid in the court of law? And is it necessary? Do you need, in fact, these imagings to support your treatment, your management of the topic? So these are all the things that easily come to our mind, and we have to look into that to get the genuine answer. So our main aim here is to give some of the important overview of normal imaging, but here I'm going to focus only on ultrasonography, and I may be touching MRI and CT scan here and there, but I will focus on ultrasonography because most of the obstetrician and gynecologists, they own their own machine in their clinical nursing homes, and it will be useful for the students as well because this is an important clinical entity. Patients coming with lower abdominal pain, especially the female patients coming with lower abdominal pain and menstrual irregularities, quite common. As you have seen from the two speakers, the incidence is very high, 40% in the Western countries, and East Asian countries about 20%. And in certain countries, of course, it ranges to 6 to 10%. This high prevalence invites us to focus on these things. So in learning outcome, I will be also reviewing some of the important points about the follicles and cysts in the ovary, which will confuse with our current topic of polycystic ovarian syndrome. And also I'll be talking about different modalities of imaging and their importance, weightage that we must give to them, and what is the preference of modality. These are all the things that we have to discuss. And finally, we will discuss about how to reach the diagnosis and differential diagnosis, how to rule out other important differential diagnosis. And also, we'll be touching upon another important condition of the lower abdominal pelvic pain, that is myoma, leiomyoma, or so-called fibroid. So we will be discussing about that and what are the diagnostic traps on imaging concerning the fibroid and what is the take-home message today. So these are all the outline in my coverage today. And I want to highlight that polycystic ovaries are very, very important because the two speakers, Eugene, Prof. Eugene and Anitha, have covered extensively. But I want to emphasize two important points: that ignorance or ignoring the clinical entity, whether it is polycystic ovary or whether it is a fibroid, it may be leading to some other uncurable diseases. Say, for example, these people have got very high risk because of the hormonal imbalance and because of the chronicity of the disease. And so there are every chances for getting this endometrial hyperplasia and carcinoma of the uterus. And also to the list, they have added another two carcinomas, that breast carcinoma and ovarian carcinomas in the list. So to that extent, these people are at high risk, and moreover, they are prone to develop this metabolic syndrome. You know pretty well that it has got its own risks of cardiovascular accidents and cerebrovascular accidents. So because of the inherent increase in the levels of triglycerides and other lipids. So we have to be very careful in considering these two conditions, and we have to make an early diagnosis. So imaging, is it crucial for making a diagnosis of ovarian disease, especially this polycystic ovarian syndrome? So the answer is yes. But literally, if you follow the medical advices, that is the Association of UK and America, so recently they concluded that imaging, yes, to be done, but it is not necessary to make a diagnosis of polycystic ovarian syndrome. What they mean is, if the patient has got menstrual irregularity by the histoclinical features, because no lady, no woman will give a false statement on this. So you have to rely on her history and also on hormonally, if there is hyperandrogenism. That two things will fix the diagnosis. Of course, we need imaging for evidence-based management. That's a must. So for any problem arises, we have to give this as a solid evidence, and so we need. And also, imaging is very interesting in these conditions. And when you look at the images which I am going to show you, you may love it. So please go with me to see all these images, so that you will have an idea of how to make a diagnosis. And in the modern era, with availability of 3D images, we have gone to the extreme of the feasibility of making the diagnosis very easily. And also we can get a real picture. Okay, before that, to the advantage of our students, and also to make a quick review of what we know already, let me touch upon the applied anatomy of this urogenital system, especially this uterus appendices. Okay, so you can see that we know pretty well, most of us, I mean, most of women have antevated uterus, which looks like this. So the posture will be like this, and the fundus and its adjacent part will be anti-flexed. So antevated and anti-flexed is the normal uterus. Okay, when it goes in the opposite direction, then you call it as a retroflexed, and this can be also seen on image. So when you see the image, especially ultrasonographic image, you will be seeing this bladder anteriorly. Next to that, posteriorly, you will be seeing this uterus. And when you look at the fundus, when it is directed posteriorly, and when it lies like this, then you can say comfortably it is retroverted uterus and also retroflexed uterus. So when you look at the image, you can say this, you can especially when you do the transabdominal ultrasonography. So you will, the first structure that you come across will be the distended bladder. Next to that will be the uterus and ovary. So when you have when you see the long axis of the uterus making 90-degree with the long axis of the vagina, okay, so it is retroverted. When it makes increased angle, but this time you are not making an angle steady with the axis of vagina, but with the axis of the cervix itself. So when the angle is 120 or more, then you will call it as retroverted uterus. Okay, so this point that you can remember, and during the ultrasonography, after seeing the bladder, so that means when you are trying to look at the pelvic structure, especially the uterus and ovaries, the bladder must be full. So you give at least 2 or 3 glasses of water to the patient before scanning, before at least 1 hour or 1.5 hours, and ask them not to pass urine. So keep the bladder distended. So that will be helping you to look at the uterus and adnexa very, very clear. So what are you going to look at? So you are going to see the entire uterus, whether it is a transabdominal or transvaginal. You will be seeing the entire uterus, okay? And in the uterus, you will be seeing the outer serous coat and also the thick muscle bundle and the inner endometrium opposed together. And you will be seeing the cervix and extension of from here, it will be the vagina. And on the transverse section, you will be seeing the uterus and also ovaries on either side. So that will be the picture when you use the transabdominal. But transvaginal is preferable. Transvaginal is useful because you are taking the end of the probe very close to the organ, and so you will be seeing very clearly the structures. So now you can see through the transvaginal probe, you can see the fundus very clearly, and you can see the myometrium, and you can see the endometrium very, very clearly. The measurement of this structure and making a baseline is very, very important on imaging. Whether the patient is having some pathology or not, if it is your patient and when you are making the record, you please measure all this and make a baseline and record them down so that in future you can easily refer, and even when you see very minor disparity in the measurement, then you can suspect the pathology and you can clearly follow the case. Very important. And also for the current cases also you have to measure. For example, the endometrium plays a very important role to tell you whether the hormones are in balance and whether the patient is having a good response of the uterus to the hormones. How? Normally, I just now I showed you, okay, 1 minute. Okay, just now I showed you this hyperechoic line is the endometrium, 2 endometrial surfaces opposed together. Okay, this is the endometrial cavity. So this is the normal prevalence. So this sort of endometrium will be occurring in the early phase of the menstrual cycle. So, but when you do the scan after some time, because of the secretory phase, this endometrium will get thickened due to the hormonal influence. So when you measure, so you can make a record, because this reflects the normalcy as well as the pathology. So that is very important to measure this endometrium. So you can measure both longitudinally and transversely. And if it is more than, say, for example, more than 10, then you have to be very, very careful, because normally in normal individuals, we get about 5 to 7 millimeters. So more than this, you have to be very careful. And secretory endometrium is will be up to 16 millimeters normally, because that is the thickest measurement during the normal menstrual cycle. And in proliferative, that is early phase, you will be getting about 11 millimeter, but normally I have seen 8 to 9 millimeter is the upper limit in many women. Okay, and when you see when you extend down, you see the cervix, and you can see the vagina with two parallel walls and hyperechoic vaginal inner part. So this is the vagina. You can see that also very clearly on our ultrasound. And coming to the study of the ovary, you can take the longitudinal view as well as transverse view, and measurement is also here very, very important. But people measure the length as well as the breadth, that's all. But what I suggest, you make it a habit of measuring 3 dimensions. It is the length, the width, and the breadth also, that the thickness also very, very important. And also you train your eyes to pick up small follicles in the ovary. These are all the things which will help you whenever you deal with the case of infertility. Very, very important. And also to be sure whether the patient is having ovarian, that is ovulation cycle or not. So this is, you are going to do ultrasonography and decide whether the patient needs any hormonal treatment or not. So these are all the things that are very important for you. You have to concentrate on that. So how to have the volume of ovary? Just now I told you, you make a 3 measurement. One is the length, another is the breadth, another is the thickness, and you multiply all of these 3 things, and you multiply with the constant factor 0.523. So, or approximately 0.5, then you will get the ovarian volume. So that is very, very important for making a diagnosis. And when you look at the ovary, normally you will get a centrally hyperechoic and peripherally a little bit hypoechoic. But in the cases of cysts, you will get beautifully like this, many cysts, a few or many, depends upon the condition prevails. So you can look at these cysts and you can decide whether they are normal or abnormal. And with the 3D, you can beautifully see the arrangement of the cyst in the periphery of the ovaries with the central area hyperechoic. So this is the appearance on 3D, and very beautifully you can see. In a normal woman, when you see, you can see the development of the follicles in the early stage of menstrual cycle, and when it goes on, this follicles slowly regress except 1 or 2. The one which is becoming bigger and bigger is called the dominant Graafian follicle, and it will look like this. Okay, it will be bigger than the other smaller cyst which may disappear later on. This one persists till the ovulation because the oocyte will be living here. And when the tension due to the secretion increases around 14th to 16th day, it will burst out and the oocyte will be released. And after releasing the oocyte, the job is either to seal immediately and do the other job, wait for the other instruction to do the other job. So then this area will be called as follicular cyst. This follicular cyst may remain in certain women for quite a long time, 2 or 3 months, but however, we expect this to disappear in 3 months. That is the normal one. So for some people, it may disappear within, say, 1 month. Because the ovary has to produce another the Graafian follicle, dominant follicle for the next cycle. So this goes on, and you must be very familiar with all these things. This is just a recapitulation, and try to count the follicles what you see on the ovaries. And counting is easy, especially now 3D is available, so you can count on the you can count lengthwise, breadthwise, and you can number them also. So there, if it exceeds, usually we fixed 12 as the pathological cutoff. But now these two countries, leading countries, UK and America, they have released that we should go up because of the modern equipments. We are able to see all the cysts with a higher resolution, and so we can rise up this number of follicles to 20 to make the diagnosis of polycystic ovarian disease. And so you must remember that in your mind. And also, whether when we have a cyst, we do not know whether it is having any dysfunction or hyperfunction or this has to be assessed by the hormonal estimation. So while you are preparing to do this ultrasonographic assessment of the cyst, technically you have to select a high resolution probe. Nowadays probes are available even with 12 megahertz, but now averagely you can take 6 or 8, and that will be very, very useful to give a high resolution images. Okay, and patient, as I told you, patient should drink water and keep the bladder filled, but not over distended, because over distended of the bladder will change the cyst shape and size, and also the ovarian volume also will be changed. So be careful not to over distend the bladder. And also you must know when to scan whenever you suspect some polycystic ovarian disease. It is always better to scan during the early phase of menstrual cycle, say 3 to 5 days, 3rd or 5th day. But if the cycle is irregular and amenorrhea, periods of amenorrhea are there, then you can do at random, no problem at all. But you have to record when do you do this scanning. And as I told you, continuing the story of the cyst, so when the dominant follicle remains for a quite long time and it refuses to disappear, then you can call it as corpus luteum cyst. This corpus luteum cyst, if you think that you are seeing a corpus luteum cyst, you follow it for future cycle, 3 to 4 cycles, okay? And if you think that any cyst is pathological, it's your duty to follow it up and then record before declaring that it is pathological. And also, when you see the cyst, if you see a thin wall, that is imperceptible wall, and a clear content, it is quite normal. Any cyst for the matter of say. So if it has a clear fluid and the wall is imperceptible, then the cyst is normal. Only thing, you have to choose the biggest follicle and record its size. But at the same time, if you see the contents are heterogeneous, as you see here, septated, multi-septated, or if you see anything internal tumefactions or any hyperechoic areas, then you have to think of some abnormality. And when you see a thick wall like this with the thick septae, it is quite abnormal. So it can be due to hemorrhage in a cyst or due to infection. So when you think of infection, then the commonest infection that you must think of is pelvic abscess and tubo-ovarian abscess. So these are all the things that you should come to your mind. When it is beautifully arranged like this, of equal size or small change in the size, first thing that it must struck to you is the polycystic ovarian disease, especially when it is more than 10 in number. So you must think of, and also you must do the scanning on both sides, right as well as the left side. That's very important. But at the same time, I want to impress the fact that the polycysts need not be on both sides. It can be on one side. That's enough for making a diagnosis of polycystic disease. But still, I have seen many people suffering from this disease have got this polycystic disease on both sides. So we have to record whatever it is, whether it's unilateral or bilateral. What is the role of MRI in making this diagnosis? Yes, it is capable of giving you a very clear picture, but at the same time, you know pretty well it is expensive, and you have to wait for a long period, and also you have to keep yourself still in MRI the gantry for more than 30 to 40 minutes, depends upon the machine. So these are all some of the hardships in MRI, but this is comparatively better than CT scan, because CT scan has got the radiation hazards. So now this MRI gives a very beautiful appearance. You can really, you love the cyst. You see, they are arranged like pools in a row, you know. So you so you can see very beautifully. You can see here the right ovary and the left ovary. So you can in fact count the number of cysts also, and you can find out the size and shape. And moreover, the MRI is very helpful in follow-up. I will come to that point later on. So you see here, for example, CT scan, you are seeing the uterus and also the ovaries, but you are not able to make a diagnosis of a cyst because sometimes but if you carefully see, you can see the cyst. Whereas in the same patient, even when it is not perceptible in CT, but when you do the ultrasound, you can see multiple tiny cysts spread all over. So you can see here many cysts of different sizes, and this case actually has been published in a journal. I have chosen this because this case, you see, the patient has also pleural effusion on the right side. What I want to say is that this polycystic ovarian disease, beside what are all the associated risks, it also can develop ascites, it can also develop pleural effusion. So this point I want to tell you. So whenever a patient comes to you with acute abdominal pain, especially lower abdominal pain, you think of the uterus and next pathology, but never forget to think of ovarian torsion also, because ovarian torsion is an emergency, unlike polyovarian cyst or fibroid. So you have to be very careful to rule out the torsion. And simply, I can say all the equipments nowadays are provided with the Doppler. So when you put on the probe, immediately you can see the vascular supply in a normal cyst, whereas in a torsion cyst, you will not see any blood supply. Very important point to remember. And also nowadays they find out that the most important cause is the pathology with the mesotubarium, and the length speaks. When it is more length, say for example, if it is a 10 centimeter or more, then it may go for torsion at any time. So you have to remember that. So another cause of the lower abdominal pain is degeneration of the fibroid. So when you speak about the fibroid, so the medical term that we use is Lyomyoma, because most of the fibroid, most of the tissue, the core tissue is a smooth muscle. So you call it as a Lyomyoma. The rest of the core tissue is made up of fibrous tissue. So fibrous tissue and this smooth muscle tissue that forms the masses. This abnormal mass may be maybe just adjacent to the mucosa, as Prof. Eugene has rightly put it, or it may be inside the muscle layer, or it may be just hanging from the fundus, or it may be just with the pedicle attached to the outer surface, or it can be just very near to the serosal surface. So depending upon the position of the fibroid, the presentation vary. You may expect a very high incidence of early presentation when the mass is submucosal, or if it is a fundus, and as well as the incidences of abortion, miscarriages are high when the fibroid is within the lumen, when you see like this. So these are all some of the points that you can keep. And you see, if the mass is in the subserosal layer, patient may not come to the hospital at all, and she may live for many years without any problems. So these are all some of the things, but this pedunculated fibroid can undergo torsion at any time. So you have to be very careful when the patient complains of acute pain. And Prof. Eugene has shown a live picture of fibroids. So fibroids can be multiple and of various sizes, and how the imaging will help you to reach a diagnosis. So I must tell you, on plain X-ray, you can see the fibroid, because Prof. Eugene, he has told that about 15 to 20 centimeter size he has seen, but I have seen also bigger than that. Also, you see, for example, the fibroid may cause enlargement of the uterus up to the cephalosternum level, and people may think that she is pregnant, and only when some investigation is done, no baby inside. And so the plain X-ray can show you a soft tissue mass pushing all the intestinal loops away from its sides. So you cannot see any loops of intestines. And scanogram from the CT scan or MRI, you can see the soft tissue mass and the internal content of this also, and pushing this all the loops of the intestine outside its arena. So the another point that I want to say is you can see calcifications in the true pelvis. So whenever you see calcification in the true pelvis, immediately you must think of either vesical calculus or uterine pathology or teratoma dermoid. So these are the four things that must come to your mind, especially for undergraduates for their consideration and discussion. And when you look at that, you can see the calcification, the type of calcification, whether it is a rim calcification confined only to the rim like this, or whether it is punctate like this and looks like sometimes a little bit thicker, like a popcorn appearance. So the typical appearance of popcorn is due to the fibroid calcification, but fibroid can also be calcified in some other way. For example, you look at this, it may be calcified like this, or the entire core may get calcified like this. So you can get only the peripheral calcification like this. So in many ways it can present, but popcorn is the typical of the fibroid. So you can remember here, you must be careful to look for calcification. You see the true pelvis appear to be normal, but when you look at the peripheral area, you see higher density over the left hip area. So something fishy here. So when you do the other investigation, then you find a big mass with calcification that is due to the fibroid. So you can, very interesting it is, when you see, this is another case when it was when I saw this, I thought that it is vesical calculus. To be frank with you, I thought like that. But when I read through the article, then I come to know that I missed the diagnosis, because it's not vesical calculus, it is vaginal calculus. So you see, when you do the imaging, then you see the calcification distally Okay, so it is posterior to the bladder, and it was proved to be a vaginal calculus. So to that extent, it can become bigger. So as far as the fibroid is concerned, the easiest and quickest way of diagnosis is doing the ultrasonography. Whether you choose to do transabdominal or transvaginal, that doesn't matter. If you do properly, I think we can make easy diagnosis of fibroid, but I prefer to do the transvaginal because transvaginal, as I told you earlier, can give you the clear picture of the not only the fibroid, but also it can show you the inner architecture. So transvaginal is very good, and you can see here. You can see here. Pardon me. You can see here there is a mass, big mass, and you can measure the mass, and you can understand that it is heterogeneous with multiple the hyperechoic and hypoechoic areas mixed together, and you can see the irregular mass. And whenever you see like this, outside the uterus, but with attachment, then you can think of subserosal fibroid. Subserosal fibroid may be asymptomatic for quite a long time. And when a fibroid is noted within the cover of the uterus, pushing the endometrial lining, that means it is submucosal. You must be very careful about this fibroid because menorrhagia and also abortions, miscarriages, and quite frequent pain, abdominal pain, all will come. And I want to tell you, the fibroid may go on for a quite long time, but if the patient is unlucky, the fibroid may undergo degeneration, the degeneration of several types: hyaline degeneration, mycoid degeneration, myxoid degeneration, hemorrhagic degeneration, so many varieties. But whatever be the variety, the patient will have acute colicky, sharp abdominal pain. So that must prompt you, especially when you know that already the patient has got fibroid. So immediately you must look for the medical emergency, because degeneration can go unnoticed if it is only minor blood supply, minor vessels are involved. But pardon me.
Excuse me, Prof. Kareem. There's another 5 minutes left.
Okay, graceful. Thank you. Okay, so the imaging show you the central necrosis, and you can easily diagnose the degeneration. So MRI is the most reliable the diagnostic method. That is because it can give an idea where exactly the zone of involvement, where the mass is, whether it is submucosal or subserosal. The zone is clearly shown to you, and also even 5 millimeter sized fibroids can be diagnosed easily by the MRI. So you can see very well, beautiful image. So you can see you see here, unlike the other picture, this one is heterogeneous and hypo-intense, not hyper-intense. So you can see beautifully the bladder and also the uterus, normal placement of the uterus. But when you look at the ovaries, and it shows multiple small cysts. So it can coexist with the fibroid. And also you can see the degeneration very clearly in the MRI picture. So you can see the central necrosis. You can see, and on T2 it will be hyper intense. So you can see all these findings very nicely on MRI. And you see here, when you see a big ovary, big uterus, and when you see fine small hyperechoic area, you think of adenomyosis. It is not fibroid. So you can see here another case. You can see multiple hyperdense areas in an enlarged uterus. That means diffuse adenomyosis. These are all some of the tips that you can use for the easy diagnosis. And also when the mass is extensively go for degeneration, the whole of the mass will become necrosed. And you can see sometimes the coexistence of the cystic ovaries as well as the fibroid. And so the topic selection is very good. Prof. Eugene has selected a top topic here to discuss. Okay, so but instead of doing the ultrasound or MRI alone, if you combine this together, it will be very, very useful because you will be seeing all the features of the fibroid. And the discussion will not be complete if I don't touch upon the latest treatment that goes on for the past 20 years, non-surgical treatment, or it can be combined with a surgery, that is uterine artery embolization. The idea is to block the blood supply and make the fibroid necrosed and follow it up for a few years. If it disappears, it's okay. Or if it is not disappearing, then its size alone may regress, make the surgery easy. So you have to selectively you inject into the uterine artery to see the excessive blood supply to the mass. And also after the embolization, you can see that that area is very clear, and you can see the adjacent arteries are very, very clear without any oversupply, without any excessive number of blood vessels. So these are all some of the important things that we must do, and follow-up is necessary. So before the embolization, you must make a measurement, and a few months after measurement, you must make a measurement, and you can appreciate the difference between these two before and after this the embolization. So these are all some of the useful things. And when you do the embolization, the mass get regressed with calcification. So that is an expected sequelae. So don't worry about it. So just to record it, the calcification is not worrying. So when you see the mass with his bizarre appearance like this and multiple small masses studded together, then you can think of Lyomatosis, a plural form of Lyomyomatosis. Okay. The differential diagnosis for this is lipolyomatosis. That means the fat component will be higher, but that can be easily made out by doing the ultrasound. Instead of hypo, it will be hyperechoic. And also in MRI, instead of hypo, it will be hyper. So that gives an idea that it has a fat core embedded, and it's easy for you to diagnose this condition from a malignant condition called leiomyosarcoma because of the associated enlargement of the lymph node and involvement of the other metastases, mother areas, or involvement of the pelvic bones. So you can easily make a diagnosis of leiomyosarcoma. So the take-home message is you have to be very careful whenever a patient comes with the lower abdominal pain. And that pain, if it is dull, it's okay, so you can treat. But if it is acute, sharp, you must think of some emergencies as well. And when the patient is having definitely irregular menstrual cycle with hirsutism, as Dr. Anitha has explained you clearly, then when you see multiple cysts on both ovaries, so you can make a safe diagnosis of polycystic ovarian syndrome. And also you must be careful to rule out other risky factors like hypercholesterolemia, triglyceridemia, to avoid these cardiovascular accident and cerebrovascular accidents. So with that, I think I'm coming to the end. Thank you very much, the chairman. And thank you very much for having given me the chance. And thank you all participants for listening to me. Thank you very much.
Very much, Prof. Kareem, for a very detailed and informative talk. Right. So with that, we come to an end to this webinar. I will put up the QR code now. I think there's been multiple requests already. Kugan, would you mind sharing the QR code so our participants can scan the QR code? Do not worry, it will be up throughout the Q&A session. Okay, so you can get your MMA app and scan it. For those who do not have the MMA app, please fill in your link, details in the Google form link that Mr. Jaidev has already put in the chat box. Okay. With that, now we will open the session for Q&A. There have been some questions in the chat box that has already been answered by our speakers. If there are any other questions, you may directly ask our speakers.
Yeah, we'll be glad to answer any questions. Anybody have got any questions? Anybody, any questions?
Perhaps we can also give the answers to Dr. Anitha's case scenarios earlier. Dr. Anitha, would you like to just take us through very briefly through the diagnosis for your case scenarios while we are waiting for more questions to come up?
Yes, Dr. Purnitha. Should I share my screen
Yes, yes, you may.
for the scenario? Or just I'll discuss the answers.
Yes, perhaps very briefly, we could just go through the answers. Yeah.
The first case scenario, actually, she is a 30-year-old Malay, unmarried, and she's not sexually active. She presented with a 1-year period of amenorrhea. And from the beginning, you know that her menstrual cycles are irregular. And she tried to lose weight previously, about 5 years back. She doesn't know the diagnosis yet, but she thinks that it can be Pcos. That's the terminology she used, because some of her friends said that she might have a Pcos. So she did some online research, and she thought she has a Pcos and tried to reduce weight by a lifestyle modification on her own. And with that, she was able to reduce about from 105 to 95 kg. She lost about 10 kgs. And during this pandemic, she lost her job. She was a teacher, primary school teacher. She lost her job, and she was so stressed, and she had altered eating patterns. You know, eating disorders are very common with the PCOS. So you need to address that if you think it's necessary. Along with that, absolutely no physical activity resulted in regaining weight up to 125 kg now. Earlier, she mentioned that she already had a thyroid function test, which was tested at 14 years. So probably, most probable diagnosis is PCOS in this condition. 2 features are satisfied, which is amenorrhea, secondary amenorrhea. The other one is acne, the clinical feature of acne. So you can perform ultrasound in this case, but it's not necessary. Only 2 features are enough. However, you need to exclude other diagnosis. So most probable diagnosis in this case can be polycystic ovarian syndrome. The second one is my friend who underwent IVF second cycle, and she had nausea and vomiting. So always remember, you need to rule out ovarian hyperstimulation syndrome. So it can occur following IVF in PCOS. So it can present from mild to severe varieties. You know, sometimes they require admission in intensive care unit. So in her case, she was admitted in the hospital immediately, and she had to be admitted in HTU because she had ascites and mild pleural effusion, but it will resolve slowly. And ovarian hyperstimulation usually occurs if it is a pregnancy. They are also more prone for thromboembolic episodes. So prevention of venous thromboembolism is very important. So you need to if she has multiple risk factors, you need to start low molecular weight heparin. So, because of dehydration and also shift of the fluid from to the third space. Okay, so with the conservative management, definitely in this case, it will be prolonged because of the pregnancy. If there is no pregnancy, the ovarian hyperstimulation syndrome can resolve quickly with the supportive management. In some cases, we need to do surgical intervention like pericardiocentesis or ascitic fluid tapping. Otherwise, we need to just monitor with the conservative management. So nausea, vomiting, you antiemetic, and IV fluid, you replace IV fluid. Strict IO chart is important. You should not overload with fluids. Then third case, PCOS presenting with the heavy bleeding and endometrial thickening, you need to rule out endometrial malignancy. So in this case, it was like a atypical hyperplasia. So atypical hyperplasia can be already associated with the endometrial malignancy. 50% of atypical hyperplasia can have coexisting endometrial malignancy. Perhaps Prof. Eugene can share his experience about different spectrum of endometrial hyperplasia and endometrial malignancy in PCOS, because he's a gynae oncologist. Thank you.
I think it is common to find endometrial hyperplasia in PCOS patients, but luckily to find endometrial cancer is present, but not that high now, but need to be assessed.
There is a question. Yeah, there's another question in the chat box. The question is there any food to avoid for a person with fibroids?
I think I have seen many patients with fibroids, and then when you talk to them and take the full history, then you look at them and then they will say they've actually been taking Chinese herbs after every period, even from young, from the age of 15, 16, the grandmother will boil for her. And these are very young patients. They come at the age of 26 with fibroids, or 28 with fibroids, and not just one fibroid, they got 3 or 4 or 5 fibroids. I'm not sure about Indians or Malays, but among the Chinese, very common. They will take something called Pak Fong Yun, and some other Chinese herbs, which they take regularly, almost for every period. The mother will boil or the grandmother will boil, and they always end up with fibroids. So we do not have double-blind control studies to look at the causation of these Chinese herbs to fibroids, but I see it very regularly. And young ladies who are in their 20s who shouldn't be getting fibroids have fibroids. So that's one. And now there's a trend of people taking collagen. And a lot of patients take placental tablets, so that they always look young. But whether these actually cause fibroids, nobody knows. Thank you. I think
display the QR code again, because some of the participants were not able to scan it. Can we have the QR code up again, please?
I think I need to answer one question, and that is somebody asked in the chat box, do we need to do to remove the uterus or not? That is a golden question, and that can only be decided after assessing the patient and all the tests that we've mentioned, including scanning, pap smear, ultrasound, cancer markers, and vaginal examination to see if it could be a good or a bad fibroid. So it also depends on the age of the patient. Of course, if she is 35 years old, not married, single, hoping to get married or going to get married next year, and she got a fibroid, that is another issue. Of course, we will remove the fibroid and not the uterus, provided it's not cancerous. Of course, if the lady is 55 years old, she's already got 6 children, and she got many fibroids, and it's not going to shrink, it's a big fibroids, and the cancer marker is elevated, and it looks like it's a huge hard fibroid. Needless to say, for that lady, she will probably need to remove the uterus together with the fibroids. So it depends on the circumstance.
There is one last question. Is stress a factor for causing PCOS? Is stress a factor for causing?
Yes, sir. Is stress a factor for causing PCOS?
Yes, that was the question from the participant.
Actually, it can be a confounding factor, but per se, it may not cause PCOS, because if there is other issues like ovarian dysfunction, ovulatory dysfunction, and she is obese and hyperandrogenic feature, because it's not included in the diagnostic criteria. So stress can have an impact in a different way. Okay. So
As Dr.
but
Anitha mentioned,
exactly,
yeah.
what is the question, Doctor? Actually, I was filling the Google form, so I was a bit lost. Sorry.
Okay, I think you answered the question. I mean, the participant wanted to know if stress was a factor that could lead to PCOS. Yeah, yes, it was one of the factors. Okay, there are no other questions. We like to thank all our participants for being very active and interactive with us and joining us on a Saturday afternoon. Please do enjoy the remaining of your Saturday with your families. Please look out for further announcements on other series for the women's health webinars. I would like to end this session by thanking all our speakers who have been excellent, and let's be an advocate to emphasize the importance of women's health. I would like to end this session with a great quote by the famous poet Maya Angelou, when she says that when women take care of their health, they become their best friends. So please, let's educate all our women to take care of themselves and their health, so that, you know, all our women stay alive for very long and are able to be productive and enjoy their lives with their families. All right, with that, thank you very much, everyone.
Thank you, everybody. Thank you. Okay, bye. See you.